So I'm just going to start with a general overview of what is HCM, kind of some bird's eye view highlights of how we diagnose it, what it is, what it's not, what considerations we have when we are thinking about this disease. And so HCM is a genetic disorder, so we're born with these genes. You may have had it passed on to you from your parents, or you may be the first person that developed this mutation, and it encodes for contractile proteins in the heart. So inside the muscle cells, they make the heart generally squeeze harder than normal, and that results in abnormal thickening of that heart muscle. We also want to take into account that this happens without having some other stimulus for the heart to get thick. And here's an example of what a normal heart with normal thickening versus an HCM heart with increased thickening, in this case in the septum, but that thickening can happen anywhere in that heart. It's common, so people ask me, is this really rare? It's actually very common. 1 in 500 or so people carry these gene mutations. We think there's about 80% of people that are undiagnosed and living out there with HCM. It can be associated with obstruction of blood flow, heart stiffening, arrhythmias, but it can also be completely asymptomatic or symptom-free. So there's a wide spectrum of how HCM can exist and present. There is no one confirmatory test. So sometimes we have these conundrums where your heart's a little bit thick and we can't tell for sure. Unfortunately, we don't have one test that tells us absolutely if this is HCM or not. So it's diagnosed by imaging studies, by our physical exam and seeing us in clinic, and by excluding other reasons that may make the heart be thick that are not HCM. So along those lines, what is not HCM? Increased thickening of the heart muscle from other conditions, such as long-standing high blood pressure, particularly if associated with long-standing kidney disease. Valvular heart disease, like stenotic aortic valves, can cause the heart to get thick. And conditions where substances deposit in the heart, where frequently one of our main things we're looking for and mimics is a condition called cardiac amyloid. So a lot of you will have testing to make sure you don't have cardiac amyloid or Fabry's disease. And then lastly, rarely, occasionally, we get athletes that are incredibly fit, that are high-functioning elite athletes that can remodel their hearts to get bigger or thicker, so we have to make that distinction in those patients too. So in terms of diagnosis, there are multiple genes that can cause HCM. So when we do genetic testing, we find a causative gene about 40% of the time. Therefore, a genetic test cannot be our test to decide whether you have this or not, or we would miss 60% of the cases. The ECG is also not sensitive or specific enough to diagnose it, so when we're screening, we really need echocardiograms for this, which is the main tool. And here on the top, we have an echocardiogram in a normal individual with normal thickening. Sorry, I showed 2 pointers on my screen. And abnormal thickened septum here in an HCM patient. And then from a different perspective, this is the septum here. We see how it's thicker in this patient. Also notice the mitral valve in a normal patient is retracted back here and short, versus in this HCM patient, it's long and more anterior, closer to that septum. And so other tests we commonly use include a cardiac MRI to confirm those thickness measurements. We also look for scarring or late gadolinium enhancement on the MRI, and we want to exclude some of those HCM mimics with that MRI. We use exercise testing frequently to assess your functional capacity, to look for obstruction with exercises in some patients that don't have obstruction at rest, and to evaluate for arrhythmias with exercise. And then the treatment, we'll cover arrhythmias in a later talk, but it's mainly focused on alleviating symptoms. So if you have symptoms and you come to see me, we're going to try to get to the bottom of what's causing those symptoms. If you come to see me and you have no symptoms, generally you're doing okay, and we can just keep you on a surveillance mode. So the first step is to decide whether there's LVOT, or left ventricular outflow tract obstruction, also termed an LVOT gradient. It's also what causes that murmur that we hear. And this is done by the physical exam, but also mainly by echocardiogram. And when we do find that obstruction, we add the O to HCM, and we call it either OHCM or HOCM or HOCM. That's where the O comes in. It's for obstruction. And so this is what obstruction looks like. When the heart squeezes, and the septum's thick and that mitral valve is close to the septum, it gets pushed in and creates a narrowing right there, so blood flow becomes turbulent and we hear that murmur just like when you squeeze a garden hose, and pressure builds up, and that pressure buildup is what we're measuring with that gradient that we report. And so here's an example of a normal patient when their heart is in systole or squeezing. See how far that valve is from the septum versus in this HCM patient with a long valve and it's being pushed and getting close to the septum, creating a narrowing there. So for a lot of you, treatment focuses around treating that obstruction. We have several talks going into that. This is another example of a normal heart. When the heart's squeezing, the mitral valve is shut out here. We see the aortic valve is open, a wide open space for blood to flow out of the heart, versus this patient that has both obstruction from their mitral valve coming anteriorly, and you see all these papillary muscle or extra muscle structures that are crowding that whole space, creating a lot of problems for that blood to flow out of the heart. Treatment without obstruction will be covered separately, but we will generally alleviate symptoms by using some medicines like beta blockers, calcium blockers. This is for obstruction, I'm sorry. So treatment for obstruction will be covered in detail, but the first-line therapies are beta blockers, calcium blockers, and occasionally disopyramide. Newer treatment includes the drug Camzyos, which is a cardiac myosin inhibitor, or CMI, which was approved in 2022. And then second-line therapies, once we're not responding to medical therapy, then go into invasive procedures like surgical myectomy and a catheter-based alcohol ablation. So this is treatment for obstructive HCM. Without obstruction, we will cover this separately, but we may use some of the same medicines we use. We want to use diuretics as needed for patients that have congestion or are swollen. And in severe cases, when patients are really severely limited, we will consider transplant evaluation. And so some things to leave you with or think about. So patients come in to see me and they frequently have, they're crestfallen and they feel very bad that they've been given this diagnosis. But if we look at the prognosis of HCM relative to other diseases, we can see HCM on the bottom has a much, much lower mortality rate than a lot of other conditions. And I've highlighted with arrows some other cardiac conditions like congestive heart failure, dilated cardiomyopathies, myocardial infarctions. So HCM is not that bad a prognosis to have. And in modern cohorts of HCM patients, we see in these middle groups that the HCM-related mortality is on par with the general mortality for the general population. So, have some hopes. Don't come out of here crestfallen. Prognosis is good. But that also means we have to take care of you long term. We have to take care of blood pressure, cholesterol, obesity, diabetes, all the usual cardiac preventive stuff, because those things are going to become important for you. So thank you. That's all I have for this introduction, hopefully keeping us on time. Next up, I have Brianna Rivers, who is our genetics counselor, and she's going to talk about genetics and the role of genetics in HCM. Thank you and welcome everybody. Thank you for being here. I am very excited about this and very happy that we could make this happen for you.